Good morning, and I'd also like to thank the organizers for putting together this very important roundtable and for asking me to be part of it. So what I'd like to do this morning in my time is share just a little bit about what we've been learning in our work with healthcare systems who are interested in implementing cancer genetic risk assessment as sort of part of their standard care as a method or as a strategy for addressing health disparities. And our work has been in breast cancer disparities, but what I say will, I think, apply more broadly. And I have no disclosures. So if you think about the goal from a sort of population health standpoint, what is the goal of a precision medicine approach to cancer screening and prevention? It's really to stratify the population. And this cartoon just sort of, tries to illustrate sort of what are we trying to accomplish from a population health standpoint. So, of course, a large chunk of the population has general population risk. And these days, there's standard screening guidelines for them. Perhaps in the future, we'll be able to kind of extend this to the left to even identify a low-risk population who maybe can have less intensive screening. We're not to that point yet, certainly, I don't think. But then, of course, we know there's a subgroup of patients who have family history of cancer and a fairly decent size who may have moderate family history, not highly suggestive of hereditary syndrome, don't meet criteria for genetic counseling and testing, but still might benefit from some other interventions. So some of these patients have, for example, they might have reproductive risk factors or mild family history. They may qualify for chemoprevention and other things of that nature. So it's very important to identify them because we can intervene and hopefully impact their risk of disease. But then there's a smaller group who have a high-risk family history where they would meet criteria for genetic counseling and DNA testing. And out of that group, then there's going to be a small number who actually are mutation positive. And so how we would manage these different groups of individuals is going to, of course, vary and depends on the risk associated. So for the mutation carrier, we're often talking about preventive surgeries. For those who have a high-risk family history but don't carry a known mutation, we might be talking about MRI screening, starting mammograms at a younger age, et cetera. So the point is that from a population health standpoint, if we can stratify the population, we can begin to be more precise about our prevention and screening to really get better outcomes for our whole population. So the question then becomes, how do we go about doing that? And so, in a sort of in the real world, so this is more what it looks like. This is kind of the flood of patients that a provider sees every day. And how do we, in a fast, in a high throughput environment of the primary care setting, how do we go about stratifying individuals? And we saw the last speaker talked about all the different issues that the HEDIS guidelines or the HEDIS benchmarks, all the things that a primary care doctor is faced with. How do they, amongst all those, pick out of the crowd who are those that belong in those various population groups of risk? And so that's really where what we call systematic cancer genetic risk assessment, or CGRA, comes into play. And in particular, of course, if we're going to really begin to identify individuals before they develop a cancer diagnosis, then this all has to happen in primary care context because these individuals are not seeing oncologists, et cetera. And so a lot of our work has been to try to develop strategies and systems to do this in a primary care context and as a systematic part of primary care and really trying to figure out, is that something that can be implemented? What are the barriers and how does one go about doing that? And in particular, our work has been with health disparities, and as we talk in this conference about inequities, there are even some higher challenges perhaps to implementing this in under-resourced communities. And so how might we go about doing that? And so just from a healthcare system standpoint, just from a basic, what are the components that one has to think about in order to be able to do this sort of systematic cancer genetic risk assessment? Well, there's sort of two basic pieces of the equation. How do you actually do the risk assessment? Where do you do it? Who's doing it? How do you make it part of the workflow? What are the instruments you use to do that? But then, for those who have increased risk, what do you do with them? So where do they go? Who's going to provide the genetics care, the specialty care to deal with those patients? And there are, of course, a whole host of issues about who's going to do that, where's it going to be done, how's it going to get paid for? And so these are, I think, the two things that immediately come to mind when healthcare systems think about trying to implement this is how do we screen and how do we deal with those who we find have increased risk? But what we've learned is that the arrow between those two, meaning how do we get from point A to point B, is actually probably the most important consideration, probably the one that gets the least amount of attention. Certainly we didn't give it nearly enough attention in 4 times trying this experiment and basically failing every time. So what we've learned is this is not field of dreams. You can't just build it and expect they will come. It really doesn't work that way. And so what I'm going to mostly focus on today is what are some of the issues, particularly in underserved communities, that really affect not only how well we can do the risk assessment, but how do we get those who are at increased risk into the care they need? Because it's all pointless if people aren't actually getting the care at the end of the day. And so this slide's probably not necessary for this audience, but whenever I talk about precision medicine and health disparities, I always like to start with this slide just to kind of set the stage. And so this is a graph showing breast cancer mortality in the U.S. And as you notice, before the mid-'80s, there really was no mortality disparity. That survival for blacks and whites was the same. And right about the mid-'80s, late '80s, we start to see those curves diverge. And of course, what happened at that time? Well, that's right about when screening mammography became widespread. That's when advances in treatment, particularly systemic adjuvant therapies, chemotherapy, tamoxifen, et cetera, became really standard place. And so the point is that I think this is an excellent example of how health disparities emerge in the wake of medical advances. And you can repeat this slide with other types of cancer, with other diseases, with HIV, with heart disease. It's really the same pattern, that health disparities come about when there are advances in medicine. And so it doesn't take a genius to think, well, what's the next big advance coming? And we're all here talking about it, which is genomic medicine. So the concern is, if this pattern holds, what might be the expected outcome in 10 or 20 years? Kind of the irony is, while precision medicine and genomics, I believe, has the power to reduce that gap, if we don't learn from the past, it's not surprising if we see that that gap may actually get worse. And just to kind of illustrate my point, this is some data from one of our speakers later this afternoon, Dr. Armstrong. Both in women who have a personal history of breast cancer, as well as women without a personal but who have a family history, there's clear evidence in many other studies showing this, that there is already a significant gap in the use of cancer genetic services among African American women. And so the quote at the bottom that I like to remember is, "Those who cannot remember the past are condemned to repeat it." So how do we sort of learn from this and move forward so that we don't repeat the same mistakes and actually make this problem worse? And so that's really what we've been working on in trying to develop a systematic approach to cancer genetic risk assessment in a primary care environment. And so I just want to show you a little bit about what we learned from a study that we did, and I promise only 2 graphs, I think. So we had developed a tool, a software tool. It's an iPad-based tool to do rapid screening for genetic risk. That was designed to be done in a primary care environment. It takes about 2 minutes to do it. It was designed for just medical assistants, non-licensed staff to be able to do the assessment. And by the way, we started this study in about 2012. A few years later, the U.S. Preventive Services Task Force kind of upped the ante. In 2005, they had endorsed genetic counseling and BRCA testing. But in 2014, they really upped the ante, and they said that primary care doctors should proactively and routinely be screening for genetic risk so that women with high-risk family history were referred. So that, to the extent that that defines a standard of care, one could argue that doing this in primary care is, in some level, or at least soon, should maybe be considered a standard of care. So our study ended up being sort of a test of the implementation of that mandate. So what we did was we worked with 2 FQHCs in the south side of Chicago. We started with the usual care phase. We did typical CMEs with the docs. We did an hour-and-a-half training on genetic risk assessment and how do you manage high-risk individuals and who should be referred for genetic counseling. We had an NCI grant to do this, so our hereditary cancer clinic was free for anybody from those clinics. So we told the docs, anybody you find who has hereditary risk that you want to see a genetic counselor, send them our way. They're seen at no cost. We then said, kind of go to it. A year later, we then went back to the docs and we said, we're now going to do the assessment for you for every woman aged 25 to 69 who's presenting for an annual well visit. And so this happened while they're waiting to see the doctor. Patient goes in, the doc's given a printout that gives the results of the risk assessment and gives guideline-based recommendations. Who should be referred for genetic counseling? Who should have MRI screening? And then we did follow-ups to see what happened. And so we were interested to know 2 things. Number one, did the referral rate for genetic counseling go up when we were doing this for the doctors? And number 2, would the patients actually show up? Again, so they were being referred to an off-site counseling center, which was a university medical center in the same city, but on the different side of town. And so we screened 1,200 women. About 150 of them met NCCN criteria for genetic counseling for BRCA 1 and 2. We enrolled 112 of those women who did surveys and the like. 50 of them were seen by the same primary care doctor before and after the intervention. So we could then go back and see, we now know who should have been referred out of those 50, how many of them were referred by their doc when they were kind of on their own, how many were referred once we started doing the intervention as a systematic healthcare system sort of intervention. Not surprising, 0%. So not a single person was referred during that usual care phase after the usual approach of CME, tox, and all that. It improved to about 64% after we then began doing this for docs. So we were pretty happy with that. We thought that's a pretty good bump. I don't have any p-values up here, but you can take my word that was statistically significant. So the bad news was 0% to begin with. The good news went up to 64. Woohoo! Good, great job. Well, not really. So this now is looking at all 112 that met NCCN criteria for genetic counseling. The docs, when we took all 112, about 56% were referred, but less than 10% of those women actually came to an appointment. It was a free genetic counseling appointment. So kind of back to the drawing board. So one of the big lessons here was, again, just because we build it, that doesn't mean they will come. And so we really spent our time thinking about how do we fix that? Because again, from a healthcare system standpoint, to invest all this effort into doing this and have 10% of patients who meet requirements actually show up is really probably not worthwhile. Just to point out, so the question might be, was that only because we were in an FQHC, underserved population? So we've been working with some mammography centers doing the same basic idea. These are recent data from the last 12 months or so from 3 different breast centers. The first one's a community breast center, typical suburban demographic. The red bar is the number who met criteria for genetic counseling referral. The tool used here was kind of a little lower bar, so it was 20%. Across all 3 sites, so a community breast center, a minority-serving breast center, and a second community breast center, pretty consistently 20% met criteria. The green bar is how many of the patients expressed interest in seeing a genetic counselor at the time of the mammogram. And that varied from 40 to 50, down even to 20% in the final group. What we learned is that really just depended on the mammography text, like how much time did they take to explain this to patients. So the N group, the third center who had the lowest rate, that was the busiest. It was the biggest center. The text didn't have time to talk about it. But then perhaps the most important, how many women actually showed up for an appointment? Again, the blue bar is the percent of those who were interested. So center 1 is about 20% of those who were interested, 40% were interested. So you can see it's about 20% of when we're showing up on site. So this was in the same site, not across town. The academic medical center, even lower, is about 8% who actually showed up. And in the FAR group, it looked like they were doing great. They had about a 45%, but that was 45% of 20% who were interested. So it was 11% overall. So my point is, across the board, 5 to 10% of women were showing up for these, even on site. So again, the point here is that how we get from point A to point B is the ball game here. And from a healthcare system standpoint, again, if we're not thinking about and figuring out how to fix that, then this approach is really going to be a waste of time. I'll just point out, we did this experiment 10 years ago. We had the exact same results. I'm a slow learner, I guess. We did this in a mammography center, and almost 100% of women wanted the information. And about 200 were increased risk. Same thing, a free consult. 83% didn't show up. Only 17% came. We want to know why was that? So we did a quick little, not very scientific survey, and what we found was the 2 biggest reasons were women. And by the way, we sent them a letter. We sent them a letter saying, you are at increased breast cancer risk. Call this number for a free consultation in your mammography center. 75% of them, after they got the letter, thought, I'm not at increased risk, despite us just telling them they were. Half of them said I had a normal mammogram. So the point that I'm trying to make here is that there is an enormous disconnect between how we view future risk and how patients interpret this information when it's being given to them. And so others have talked about that gap. But again, if we don't figure out how to solve this, then we really are going to, we're not going to be able to realize the benefits that are out there. So going back to our study, this most recent with the FQHC. So we spent a lot of time working with the women who were in our original study. We did in-depth interviews with about 20 African-American women from the FQHC. Most of them did not show up. All referred, 18 didn't come, I think 2 came. And I'm not going to go through all this for the interest of time, but we were asking them about genetic counseling and like why didn't they not come and why would they come in? And these are the things that came up, nothing to do with genetic counseling. So my point is what I should have, again, figured out is that women there's a context. There's a healthcare context. There's prior experiences, and all of that dramatically colors how individuals see this, and particularly when you're talking about disadvantaged populations. But in the interest of time, I want to just jump to point 8. So what did women actually tell us about genetic counseling? Much like our earlier study, they equated genetic counseling with being told they had breast cancer. they didn't recognize that we're talking about a future risk event. And of course, these women all had a family history. And so many of them had very negative experiences with breast cancer. So the emotional baggage that accompanies a breast cancer diagnosis was traveling with the genetic counseling. So women were equating the two, and all the negative feelings about breast cancer were being transferred. So they basically were saying, I had my mammogram, I'm good, I don't want to deal with this anymore. And so when we actually, in the interviews, spent time explaining exactly what the purpose was and how it would empower them, every single one said, oh, if I'd have known that, I would have done it. Of course, we thought they did know that because their doctor had given them the result and had referred them. So we were assuming that the doctors were explaining all this. And so we were scratching our heads a little bit. Well, why did they not understand this? We designed the study this way so the doctor would recommend it and all that. We did focus groups with the doctors, and you can imagine what they told us. They said, we love this. This is great. We don't get it. Like, we don't know what happens in genetic counseling. And these are, again, very bright doctors, but they didn't experience it firsthand, so they didn't know what to tell women other than, you got breast cancer in your family, go talk to these people, they'll help you with that. They didn't themselves understand it well enough to be able to really motivate the women to do it. So they told us, you got to help us. You got to come up with some ways that we can, educate and motivate these women. So that's what we're doing. So our work now, we're really focusing on developing educational, motivational interventions to deal with that. So last slide or two. So this is kind of how we've been thinking about this, how do we solve that arrow problem? How do we get from point A to point B from that system standpoint? And again, if we don't think about all this, we know what's going to happen. We've done that experiment too many times. So this is a theoretical model that is used to help kind of predict health behavior. And so the model basically says that intentions are the primary driver of action, of healthcare action. So the intention to engage in genetic counseling is the primary motivator to do it. But then what influences the intention? Well, it's a variety of ideas. So attitudes, expected outcomes are a key one. Perceived social norms in this case are important. But also environmental constraints can influence or modify how strongly the intention can actually produce the action. So we have to be addressing what are the environmental constraints, the access issues, having to drive across town to a big university, that's a scary place because I'm used to a small clinic and I got to go to some giant place and I got to pay to park and I don't know where it is. All of those things really are important as well. So as we think from a system standpoint, how do we intervene? Education and awareness is really critical. And again, it can't simply just be handing a pamphlet, but we really need to think creatively, particularly for underserved populations. How do we address all those other issues that surround the healthcare experience that are really coloring their interest in or not interested in doing genetic counseling? We're very interested in a new paradigm that we call point-of-care genetic counseling, where we actually can provide the care on site. So in FQHCs, using nurse practitioners and the like. I think we need to really rethink how do we deliver genetics care in the genomics age, because there's clearly a workforce shortage and we're going to have a real problem. When you think about it, 10% of women in our study met criteria for genetic counseling, 10% of adult women. If we actually did this across the population, the numbers of people we're talking about would overwhelm the genetic counseling workforce in about a week. So we need to be thinking about new models. Telemedicine's one, but we may even need to think of other ways of really providing this care. Just these are some of the important issues that, again, a healthcare system has to think about when we're talking about the assessment process. What's the business model that will make this work? If you're a FQHC and you're screening and you're referring everyone to a university, what's in it for me? Very little. It's all expense and very little. So it's not a viable model. In our study, it was funded by a grant. The FQHC loved it, but when the grant went away, they said, even though it's 3 minutes to do the assessment for their MAs, they said, we can't afford that extra time. So that's not a viable model. So how do we come up with a model if it's a clinic? If it's a mammography center, MRI volume may actually support it. So again, thinking about where you're trying to do it really influences the model that you have to come up with. And these are just a variety of other topics I won't go into. We can talk about them during discussion if people like. Who's going to be the genetic specialist? Where is that going to be done? Is it on site? What I didn't tell you, the mammography centers, the 3 that I showed you, the one that had the highest uptake, it's because they did the counseling on site and the person coordinating it went to each woman when they had their mammogram and said, hi, my name's Danette. I'm going to be setting you up for your genetic counseling. Let me tell you a little bit about it. There was a stick factor because they were actually on site talking about it, bringing the fear level down and explaining it. So where you do it how you do it, all that matters a great deal. How do we provide coverage for these enhanced interventions, particularly for under-resourced individuals? Again, and we can't get the spigot going without a way to deal with it at the other end. So how are we going to manage all these women if we have a significant number who are uninsured or underinsured? But again, those are I think the things that are obvious. What's less obvious is dealing with that problem of getting from point A to point B and really being creative about how we do that. What we've learned is that what you decide about the CGRA process and how you're going to do that, and what you decide about who will do the genetic specialty care dramatically influences the success of getting the patients into the care they need. So all of these things are actually very much related, and you have to really think through all those pieces to come up with a system that's going to not only be financially viable, but also actually will work. And so just my last slide. So we're thinking about, and we were told we could kind of pitch some new ideas here, so here's my pitch. So as I said, we're thinking about a new paradigm for doing this sort of population health cancer genetic risk assessment in primary care, and that's what we've been calling a point-of-care genetic counseling, where we train NPs and PAs in the clinics to be able to provide what we're calling primary-level genetic care. And if you think about medicine, every other area there's specialty care and primary care. Not everybody who has diabetes needs to see an endocrinologist. Not everyone who has hypertension needs a cardiologist, but there are some who do. We don't do that in genetics. We really, it's kind of everybody goes to the specialist. So in this arena anyway of cancer risk assessment, the majority of women test negative and don't really need a genetic counselor to manage them. They need someone who knows what they're doing and who's trained. But then there are complex cases, mutation positives, who probably do need that specialty care. So can we develop a system where we have sort of primary genetic care done in FQHCs? Can we train NPs and PAs to do that? Working in collaboration with a genetics professional. That also solves some of the workforce issues. It kind of opens up the bottleneck a little bit, and it provides a financial model that might be viable for an FQHC because now they can do the care in-house and they can support the program. So I think I may have used up my time. With that, I will thank the people who helped us do this work, and I'll end my presentation.